Did you know that one tiny medication error in a Neuro ICU can cost brain cells by the millions? In the next few minutes, we're diving into the secret life of neurocritical care pharmacists, the unsung heroes keeping stroke, hemorrhage, and brain injury patients alive and improving outcomes. From life-saving thrombolysis, anticoagulation reversal, to precise seizure and ICP management, you'll see exactly how every drug decision matters in the ICU. Stay tuned, because what you learn here could save a life. Role 1 entails evaluation and management of IV thrombolytic therapy in acute ischemic stroke. A neurocritical care pharmacist plays a decisive role during acute stroke activation. Time is brain. Every minute of untreated ischemic stroke leads to the loss of nearly 2 million neurons. The pharmacist helps ensure that thrombolysis occurs safely, rapidly, and according to evidence-based protocols. During stroke code activation, the pharmacist immediately joins the stroke response team. The pharmacist quickly reviews the patient's medication history. Special attention is given to anticoagulants and antiplatelet therapy. Recent use of oral anticoagulants must be identified immediately. Direct oral anticoagulants may contraindicate thrombolysis depending on timing and renal function. Warfarin therapy requires urgent verification of the INR. An INR greater than 1.7 usually excludes alteplase therapy. The pharmacist rapidly verifies laboratory values. Platelet count must be above 100,000 per microliter. Blood glucose must be evaluated immediately. Severe hypoglycemia can mimic stroke. Correcting glucose may reverse neurologic deficits. Blood pressure is assessed simultaneously. Thrombolysis requires blood pressure below 185 over 110 millimeters of mercury. The pharmacist recommends appropriate IV antihypertensives if pressure is elevated. Nicardipine infusion is commonly preferred. Labetalol boluses may also be used. Clevidipine is useful when rapid titration is required. Weight-based dosing is calculated precisely. The pharmacist confirms the patient's body weight. Estimated weights introduce dosing errors. Alteplase dosing is 0.9 milligram per kilogram. The maximum dose is 90 milligrams. 10% of the dose is administered as an IV bolus. The remaining 90% is infused over 60 minutes. The pharmacist prepares the drug immediately. Reconstitution errors must be avoided. Accurate dilution is critical. The pharmacist ensures correct infusion pump programming. Dose verification prevents catastrophic bleeding complications. The pharmacist also screens for exclusion criteria. Recent intracranial hemorrhage is a contraindication. Recent major surgery may exclude thrombolysis. Active internal bleeding must be ruled out. Severe uncontrolled hypertension is another concern. Recent traumatic brain injury is evaluated carefully. The pharmacist confirms absence of recent intracranial procedures. Platelet inhibitors rarely contraindicate thrombolysis alone. However, combined antiplatelet therapy increases bleeding risk. Clinical judgment is essential. The pharmacist evaluates imaging results alongside the neurologist. CT imaging must exclude intracranial hemorrhage. Large established infarcts increase bleeding risk. Advanced imaging sometimes reveals salvageable penumbra. The pharmacist helps integrate imaging findings with pharmacologic decisions. When tenecteplase is used, dosing differs. Tenecteplase is given as a single IV bolus. The typical dose is 0.25 milligram per kilogram. The maximum tenecteplase dose is 25 milligrams. Tenecteplase simplifies administration during mechanical thrombectomy preparation. The pharmacist ensures appropriate drug selection. Drug availability must never delay thrombolysis. The pharmacist ensures thrombolytics are stocked in stroke kits. Medication preparation occurs within minutes. Door-to-needle time should be under 60 minutes. Many centers target 45 minutes or less. Elite stroke centers aim for 30 minutes. Pharmacists help achieve these targets. After administration, monitoring becomes critical. Neurologic status must be assessed frequently. NIH stroke scale monitoring is performed regularly. Blood pressure must remain controlled. The pharmacist ensures post-thrombolysis antihypertensive protocols are followed. Anticoagulants must be avoided for 24 hours. Antiplatelet therapy is also withheld during this period. A repeat CT scan is required after 24 hours. This confirms absence of hemorrhage before antithrombotics are restarted. The pharmacist monitors for early complications. Symptomatic intracranial hemorrhage is the most feared complication. Any neurological deterioration must be investigated immediately. If bleeding occurs, rapid reversal is necessary. The pharmacist recommends cryoprecipitate. Cryoprecipitate restores fibrinogen levels. Tranexamic acid may also be considered. Aminocaproic acid is another option. The pharmacist coordinates these interventions rapidly. Documentation is also critical. Stroke registries require accurate thrombolysis data. Pharmacists help maintain quality metrics. Door-to-needle times are carefully audited. Protocol deviations are reviewed. Continuous improvement is essential. Pharmacists also educate stroke teams. Training includes thrombolytic dosing and safety. Simulation training improves stroke response times. Interdisciplinary collaboration is essential. In modern stroke systems, pharmacists are indispensable. Their expertise improves both safety and speed. Ultimately, optimized thrombolysis improves neurological outcomes. The Neurocritical Care Pharmacist ensures the right patient receives the right thrombolytic at the right time. Lives and neurons depend on this precision. Role 2 entails anticoagulation reversal in intracranial hemorrhage. Anticoagulation reversal is one of the most time-critical interventions in neurocritical care. Intracranial hemorrhage in an anticoagulated patient is a neurological emergency. Hematoma expansion often occurs within the first few hours. Rapid pharmacologic reversal can significantly reduce hematoma growth. The Neurocritical Care Pharmacist becomes central to this intervention. The first task is rapid medication history verification. The pharmacist immediately determines whether the patient is receiving anticoagulants. Common agents include warfarin, apixaban, rivaroxaban, dabigatran, and edoxaban. Heparin exposure must also be considered. Low molecular weight heparins may also be implicated. The pharmacist determines the exact anticoagulant involved. Timing of the last dose is critically important. Renal function significantly affects drug clearance. Impaired renal function prolongs drug activity. Laboratory values must be interpreted rapidly. Coagulation parameters guide reversal strategies. For warfarin patients, the international normalized ratio is essential. An elevated INR confirms active anticoagulation. Immediate reversal is required in intracranial bleeding. The pharmacist recommends administration of 4-factor prothrombin complex concentrate. 4-factor PCC rapidly restores clotting factors 2, 7, 9, and 10. This correction occurs within minutes. Vitamin K must also be administered. Vitamin K supports sustained reversal. Intravenous vitamin K is preferred in this setting. The typical dose ranges between 5 and 10 milligrams. Administration should be slow to avoid anaphylactoid reactions. The pharmacist confirms appropriate PCC dosing. Dosing is usually weight-based and guided by INR level. Higher INR values require larger PCC doses. The pharmacist ensures rapid drug preparation. Time delays worsen neurological outcomes. If PCC is unavailable, fresh frozen plasma may be used. However, plasma works more slowly. Large infusion volumes may worsen intracranial pressure. PCC remains the preferred therapy. Direct oral anticoagulants require different reversal strategies. Each drug requires specific consideration. Dabigatran is a direct thrombin inhibitor. The reversal agent is idarucizumab. Reversal occurs almost immediately. The standard dose is 5 grams intravenously. It is usually administered as 2 consecutive infusions. The pharmacist ensures rapid availability of idarucizumab. For factor Xa inhibitors, other strategies are required. Apixaban and rivaroxaban inhibit factor Xa. The specific reversal agent is andexanet alpha. Andexanet alpha acts as a decoy factor Xa molecule. Binds circulating Xa inhibitors. This restores endogenous clotting activity. The pharmacist determines whether the patient qualifies for andexanet alpha therapy. Dose selection depends on the specific DOAC and timing of the last dose. High-dose and low-dose regimens exist. Administration involves an initial IV bolus. This is followed by a continuous infusion. The pharmacist carefully calculates the infusion protocol. Cost considerations may influence institutional decisions. Some centers prefer PCC for DOAC reversal. Evidence supports off-label PCC use in factor Xa inhibitor bleeding. Typical dosing ranges between 25 and 50 units per kilogram. The pharmacist collaborates closely with neurologists and hematologists. Reversal strategies must balance bleeding control with thrombotic risk. Reversal increases thrombosis risk. Patients may have underlying atrial fibrillation or mechanical heart valves. Stopping anticoagulation increases embolic risk. Clinical judgment becomes essential. Heparin-associated intracranial hemorrhage also requires rapid action. Protamine sulfate reverses unfractionated heparin. The pharmacist calculates the required protamine dose. Dosing is based on the amount of heparin received in the last 2 hours. Excess protamine may cause hypotension. Slow administration reduces adverse effects. Low molecular weight heparins require partial reversal. Protamine neutralizes approximately 60% of LNWH activity. The pharmacist monitors anti-10A levels where available. Continuous reassessment is essential. The pharmacist reviews follow-up laboratory results. INR and coagulation parameters should normalize. Fibrinogen levels must remain adequate. Cryoprecipitate may be required if fibrinogen is low. Neuroimaging is repeated to monitor hematoma progression. Medication reconciliation continues throughout ICU care. Restarting anticoagulation requires careful timing. Premature resumption may cause rebleeding. Delayed resumption increases thromboembolic risk. The pharmacist participates in multidisciplinary discussions. These include neurology, neurosurgery, and cardiology teams. Evidence-based timing strategies are evaluated. The pharmacist also ensures proper documentation. Reversal therapies must be recorded accurately. Adverse drug reactions must be monitored. Quality improvement initiatives track reversal response times. Hospitals aim for rapid reversal protocols. Pharmacists often design these protocols. Stroke and hemorrhage teams rely on pharmacist expertise. Simulation training frequently includes anticoagulation reversal scenarios. Rapid recognition saves lives. In neurocritical care, minutes matter. The pharmacist ensures that life-saving reversal therapies are delivered without delay. Precision pharmacology directly protects the brain. The neurocritical care pharmacist therefore becomes a key defender against catastrophic hematoma expansion. Role 3 entails blood pressure pharmacotherapy optimization in acute stroke and intracranial hemorrhage. Blood pressure management is one of the most delicate pharmacologic tasks in neurocritical care. The brain depends on precise cerebral perfusion. Both hypertension and hypotension can worsen neurologic injury. The neurocritical care pharmacist plays a key role in optimizing blood pressure therapy. Every stroke patient presents a unique hemodynamic challenge. In acute ischemic stroke, elevated blood pressure is common. This elevation is often a physiological response. The body attempts to preserve cerebral perfusion. Aggressive blood pressure reduction may worsen ischemia. The pharmacist helps the team avoid overly rapid reductions. Treatment thresholds must be carefully observed. If thrombolysis is not planned, higher blood pressures are often tolerated. Permissive hypertension may be beneficial in this setting. Blood pressure may be allowed up to 220 over 120 millimeters of mercury. This supports perfusion of the ischemic penumbra. However, if thrombolytic therapy is planned, strict targets apply. Blood pressure must be reduced below 185 over 110 millimeters of mercury before thrombolysis. This reduces the risk of intracranial hemorrhage. After thrombolysis, blood pressure must remain below 180 over 105 millimeters of mercury. The pharmacist ensures these targets are consistently maintained. Intravenous antihypertensive therapy is usually required. Short-acting, titratable agents are preferred. The pharmacist guides the selection of appropriate drugs. Nicardipine is frequently used in neurocritical care units. It is a dihydropyridine calcium channel blocker. Nicardipine produces smooth arterial vasodilation. It has minimal effects on cerebral vasculature autoregulation. The pharmacist initiates nicardipine infusion protocols. The typical starting dose is 5 milligrams per hour. The infusion may be titrated every 5 to 15 minutes. Maximum doses usually reach 15 milligrams per hour. Close monitoring is essential. Blood pressure should be assessed every few minutes during titration. Labetalol is another commonly used agent. It provides combined alpha and beta adrenergic blockade. This results in balanced blood pressure reduction. Labetalol can be given as intermittent IV boluses. Typical doses range from 10 to 20 milligrams. Repeated boluses may be administered every 10 minutes. Continuous labetalol infusion is also possible. The pharmacist evaluates heart rate before labetalol use. Bradycardia may limit its use. Clevidipine offers another powerful option. Clevidipine is an ultra-short-acting calcium channel blocker. Its rapid onset allows precise blood pressure control. Its half-life is approximately 1 minute. This allows immediate titration. The pharmacist prepares clevidipine infusion protocols. Starting doses typically begin at 1 to 2 milligrams per hour. Doses are doubled rapidly during titration. Precise control is especially useful in hemorrhagic stroke. Intracerebral hemorrhage presents a different challenge. Here, uncontrolled hypertension drives hematoma expansion. Early blood pressure reduction becomes essential. Evidence supports early intensive blood pressure control. Systolic targets often range between 140 and 160 millimeters of mercury. The pharmacist helps select the safest antihypertensive strategy. Rapid fluctuations must be avoided. Excessive blood pressure reduction may reduce cerebral perfusion. Continuous infusions allow stable control. Nicardipine and clevidipine are commonly preferred. The pharmacist ensures infusion pumps are programmed correctly. Medication preparation must occur rapidly. Stroke teams rely on immediate drug availability. The pharmacist ensures antihypertensives are stocked in emergency stroke kits. Frequent hemodynamic monitoring is essential. Arterial lines are often used in severe cases. The pharmacist helps interpret real-time blood pressure data. Medication titration must respond to these readings. In subarachnoid hemorrhage, blood pressure goals may differ. Before aneurysm securing, hypertension increases rebleeding risk. Blood pressure must be controlled carefully. After aneurysm repair, adequate perfusion becomes critical. The pharmacist adjusts antihypertensive therapy accordingly. Some patients develop vasospasm during recovery. Induced hypertension may sometimes be required. The pharmacist collaborates closely with neurointensivists. Pharmacologic agents must be adjusted dynamically. Renal function also influences drug selection. Patients with renal impairment require careful monitoring. Liver dysfunction may affect labetalol metabolism. The pharmacist evaluates organ function continuously. Drug interactions must also be considered. Sedatives and analgesics may influence blood pressure. Propofol may cause hypotension. Dexmedetomidine may cause bradycardia and hypotension. The pharmacist balances sedation needs with hemodynamic stability. Fluid status must also be evaluated. Hypovolemia may worsen hypotension. The pharmacist ensures appropriate IV fluid therapy. Electrolyte abnormalities may also influence cardiovascular stability. Hyponatremia is common in neurocritical patients. The pharmacist monitors sodium carefully. Hypertonic saline therapy may affect blood pressure. Integrated hemodynamic management is essential. The pharmacist also participates in protocol development. Stroke centers maintain standardized blood pressure algorithms. Pharmacists frequently design these protocols. Simulation training improves stroke response efficiency. Blood pressure management errors can have devastating consequences. Pharmacist oversight reduces these risks. Education is also a major responsibility. Nurses must understand titration protocols. Residents must understand stroke blood pressure targets. The pharmacist provides continuous training. Quality metrics track blood pressure control during stroke care. Pharmacists help analyze these outcomes. Improving blood pressure management improves stroke survival. Ultimately, optimal blood pressure control protects the injured brain. Precision pharmacology becomes a neurological intervention. The Neurocritical Care Pharmacist therefore safeguards cerebral perfusion through expert hemodynamic pharmacotherapy. Role 4 entails optimization of antiplatelet therapy in acute ischemic stroke and secondary prevention. Antiplatelet therapy is a cornerstone of ischemic stroke management. Platelet activation plays a major role in arterial thrombosis. Preventing platelet aggregation reduces the risk of recurrent stroke. The Neurocritical Care Pharmacist ensures antiplatelet therapy is initiated appropriately. Timing of therapy is critically important. In patients who did not receive thrombolysis, antiplatelet therapy should begin early. Aspirin is usually the first-line agent. Therapy typically begins within 24 hours of stroke onset. Early aspirin reduces recurrent ischemic events. The pharmacist confirms that intracranial hemorrhage has been excluded. Brain imaging must always precede antiplatelet therapy. Computed tomography is the most commonly used modality. Once hemorrhage is excluded, aspirin may be administered safely. Initial aspirin dosing is typically between 160 and 325 milligrams. This loading dose rapidly inhibits platelet aggregation. Maintenance dosing usually ranges from 75 to 100 milligrams daily. The pharmacist ensures accurate dose selection. Gastrointestinal protection may be necessary. Proton pump inhibitors may be recommended in high-risk patients. Drug interactions must be evaluated carefully. Some proton pump inhibitors reduce clopidogrel activation. The pharmacist selects safer alternatives when necessary. Dual antiplatelet therapy is sometimes indicated. Patients with minor ischemic stroke benefit from short-term dual therapy. Transient ischemic attack patients may also benefit. The combination of aspirin and clopidogrel is commonly used. Dual therapy reduces early recurrent stroke risk. However, bleeding risk increases with prolonged use. The pharmacist helps determine appropriate treatment duration. Most guidelines recommend dual therapy for 21 days. Some protocols extend therapy to 90 days. Clinical judgment guides final decisions. The pharmacist evaluates stroke subtype. Large artery atherosclerosis may justify longer dual therapy. Small vessel disease may require different strategies. Cardioembolic stroke is managed differently. Anticoagulation is preferred for atrial fibrillation. Antiplatelet therapy alone may be inadequate. The pharmacist identifies these distinctions. Medication history review is essential. Many patients already receive antiplatelet therapy before stroke. Aspirin failure must be evaluated. Platelet resistance may occur in some patients. The pharmacist considers alternative agents when necessary. Clopidogrel is a common alternative. Clopidogrel inhibits the P2Y12 platelet receptor. It prevents ADP-mediated platelet activation. The typical maintenance dose is 75 milligrams daily. Loading doses may be used in acute settings. The pharmacist evaluates potential genetic variability. Some patients are poor metabolizers of clopidogrel. CYP2C19 polymorphisms reduce drug activation. This may decrease therapeutic effectiveness. The pharmacist may recommend alternative agents. Ticagrelor may be considered in selected cases. Ticagrelor provides more potent platelet inhibition. However, bleeding risk must be assessed carefully. The pharmacist weighs risks and benefits. Renal function may influence drug selection. Hepatic impairment may affect metabolism. The pharmacist evaluates organ function regularly. Bleeding risk assessment is essential. Recent surgery increases bleeding risk. Gastrointestinal bleeding history must be considered. Concomitant anticoagulants increase hemorrhagic complications. The pharmacist carefully reviews the entire medication profile. Drug interactions must be minimized. Non-steroidal anti-inflammatory drugs increase bleeding risk. Selective serotonin reuptake inhibitors may also increase bleeding tendency. The pharmacist recommends safer alternatives where possible. Monitoring is essential throughout therapy. Clinical monitoring focuses on bleeding complications. Signs include gastrointestinal bleeding and bruising. Neurological deterioration may indicate intracranial hemorrhage. The pharmacist ensures rapid investigation of such symptoms. Laboratory monitoring may include hemoglobin levels. Platelet counts must also be monitored. Thrombocytopenia may rarely occur. Education is another vital role. Patients must understand the purpose of antiplatelet therapy. Adherence is essential for stroke prevention. Missing doses may increase recurrence risk. The pharmacist provides clear counseling. Patients must also understand bleeding precautions. Minor bleeding events may occur. Serious bleeding must be reported immediately. The pharmacist ensures patients recognize warning signs. Discharge planning also includes medication reconciliation. Stroke survivors often require long-term antiplatelet therapy. The pharmacist ensures prescriptions are clear and accurate. Secondary prevention strategies extend beyond medication. Blood pressure control remains essential. Lipid management is also critical. Statin therapy is commonly required. Lifestyle modification must also be encouraged. Smoking cessation significantly reduces stroke recurrence. The pharmacist reinforces these preventive strategies. Interdisciplinary collaboration strengthens patient care. Neurologists, cardiologists, and pharmacists work together. Evidence-based therapy improves long-term outcomes. Quality improvement initiatives monitor antiplatelet use. Pharmacists often analyze adherence to stroke guidelines. Protocol development improves standardization of care. Clinical pharmacists help implement these protocols. In academic medical centers, research is ongoing. Pharmacists contribute to studies on antiplatelet strategies. New therapies continue to emerge. Precision medicine may guide future treatment. Genetic testing may personalize antiplatelet therapy. The neurocritical care pharmacist remains at the center of these advances. Ultimately, optimized antiplatelet therapy prevents recurrent stroke. Preventing recurrence protects brain function. Effective pharmacotherapy preserves independence and quality of life. The neurocritical care pharmacist ensures that platelet inhibition is both effective and safe. In stroke medicine, prevention is as important as acute intervention. Role 5 entails management of anticoagulation therapy for cardioembolic stroke prevention. Cardioembolic stroke represents one of the most severe forms of ischemic stroke. It is frequently associated with atrial fibrillation. Other causes include mechanical heart valves, cardiomyopathy, and intracardiac thrombus. These strokes often involve large cerebral vessels. Recurrence risk without anticoagulation is extremely high. The neurocritical care pharmacist plays a crucial role in preventing recurrence. The first task is identifying the stroke mechanism. Cardioembolic strokes require anticoagulation rather than antiplatelet therapy. This distinction is critically important. Antiplatelets alone are inadequate for atrial fibrillation-related stroke. The pharmacist carefully reviews cardiac history. Electrocardiographic data must be examined. Continuous telemetry monitoring may reveal paroxysmal atrial fibrillation. Holter monitoring may also detect intermittent arrhythmias. The pharmacist collaborates with cardiology colleagues. Once cardioembolic stroke is confirmed, anticoagulation becomes essential. However, timing of anticoagulation initiation requires careful judgment. Starting anticoagulation too early may cause hemorrhagic transformation. Delaying therapy may allow recurrent embolic events. Balancing these risks requires multidisciplinary expertise. The pharmacist participates actively in these decisions. Stroke size significantly influences anticoagulation timing. Small infarcts allow earlier anticoagulation. Large infarcts require delayed initiation. Severe strokes carry a higher bleeding risk. Imaging studies guide these decisions. Magnetic resonance imaging provides valuable detail. Hemorrhagic transformation must be excluded. The pharmacist carefully reviews imaging reports. Neurologists often follow the 1-3-6-12-day rule. Transient ischemic attack may allow anticoagulation within 1 day. Minor strokes may allow therapy within 3 days. Moderate strokes often require 6 days. Severe strokes may require waiting 12 days or longer. The pharmacist ensures these timing strategies are followed safely. Drug selection is the next critical step. Several anticoagulant options exist. Direct oral anticoagulants are widely used. These include apixaban, rivaroxaban, dabigatran, and edoxaban. Warfarin remains necessary in certain patients. Mechanical heart valve patients require warfarin therapy. Direct oral anticoagulants are contraindicated in this group. The pharmacist evaluates individual patient characteristics. Renal function strongly influences drug selection. Apixaban is often preferred in renal impairment. Dabigatran relies heavily on renal clearance. Severe renal dysfunction may limit its use. The pharmacist calculates creatinine clearance. Dose adjustments must be precise. Underdosing may lead to stroke recurrence. Overdosing increases bleeding risk. Apixaban is commonly prescribed at 5 milligrams twice daily. Dose reduction may be necessary. Patients meeting 2 reduction criteria receive lower doses. These criteria include advanced age, low body weight, and elevated creatinine. Rivaroxaban is usually administered once daily. It must be taken with food for optimal absorption. The pharmacist reinforces this counseling point. Dabigatran requires twice daily dosing. Capsules must not be opened or crushed. The pharmacist ensures proper administration instructions. Warfarin therapy requires additional management. Frequent INR monitoring is necessary. The therapeutic range is typically between 2 and 3. Maintaining this range prevents both thrombosis and bleeding. The pharmacist provides anticoagulation clinic support. Drug interactions must be evaluated continuously. Many medications influence warfarin metabolism. Antibiotics commonly alter INR values. The pharmacist anticipates these interactions. Dietary vitamin K intake also affects warfarin therapy. Patients require detailed counseling. Consistency in dietary habits is essential. The pharmacist also evaluates bleeding risk. Risk scoring tools may assist decision-making. The HAS-BLED score estimates hemorrhage risk. However, high bleeding risk does not automatically exclude anticoagulation. Stroke prevention often remains the priority. The pharmacist helps contextualize these risks. Medication adherence becomes critically important. Missed doses of direct oral anticoagulants rapidly reduce protection. Their half-lives are relatively short. Non-adherence significantly increases stroke risk. The pharmacist emphasizes strict adherence. Patient education is a core responsibility. Patients must understand why anticoagulation is necessary. They must recognize warning signs of bleeding. Signs include melena, hematuria, and unusual bruising. Severe headache may indicate intracranial bleeding. Immediate medical evaluation becomes necessary. The pharmacist reinforces these safety messages. Medication reconciliation is also essential. Many stroke patients take multiple drugs. Polypharmacy increases interaction risks. The pharmacist ensures compatibility of therapies. Non-steroidal anti-inflammatory drugs should usually be avoided. These drugs increase bleeding risk. Selective serotonin reuptake inhibitors may also increase bleeding. Alternative therapies may be considered. Peri-procedural anticoagulation management may also arise. Some stroke patients require surgical interventions. Temporary interruption of anticoagulation may be necessary. The pharmacist guides bridging strategies when appropriate. Heparin bridging may be required in high-risk patients. However, bridging increases bleeding risk in some settings. Careful, individualized assessment is essential. Monitoring continues throughout hospitalization. Renal function must be reassessed frequently. Acute kidney injury may alter drug clearance. dose adjustments may be required. The pharmacist ensures appropriate laboratory monitoring. Transitions of care require special attention. Discharge planning must be meticulous. Clear prescriptions must be provided. Follow-up appointments must be arranged. Anticoagulation monitoring plans must be communicated. The pharmacist often coordinates these steps. Quality improvement programs track anticoagulation outcomes. Pharmacists frequently analyze stroke recurrence rates. Medication errors are also reviewed. Continuous improvement strengthens stroke care systems. Education of residents and fellows is also important. Anticoagulation management requires deep pharmacologic expertise. Pharmacists provide formal teaching sessions. Case reviews enhance learning. In academic medical centers, research opportunities are abundant. Pharmacists contribute to anticoagulation outcome studies. Novel anticoagulants continue to be developed. Reversal agents are also evolving. Precision medicine may eventually personalize anticoagulation therapy. Genetic testing may influence drug selection. Future stroke prevention strategies will become increasingly individualized. Throughout these advances, the pharmacist remains essential. Optimal anticoagulation prevents devastating recurrent strokes. Preventing recurrence preserves neurological function. The neurocritical care pharmacist ensures anticoagulation therapy is safe, effective, and precisely tailored. In cardioembolic stroke prevention, pharmacologic precision saves brain tissue and protects long-term patient outcomes. Role 6 entails active participation in daily multidisciplinary neurocritical care rounds. Daily multidisciplinary rounds are the operational center of neurocritical care. Every major therapeutic decision emerges from these discussions. The neurocritical care pharmacist is a core participant in these rounds. Their expertise ensures pharmacotherapy decisions are safe, precise, and evidence-based. Rounds usually begin early in the morning. The team gathers at the patient bedside or in the ICU conference area. Participants often include neurologists, neurosurgeons, neurointensivists, critical care nurses, respiratory therapists, and pharmacists. Each discipline contributes unique expertise. The pharmacist contributes advanced pharmacologic insight. Before rounds begin, the pharmacist performs a detailed medication review. Every medication in the patient profile is analyzed. Dosing accuracy must be confirmed. Renal function adjustments must be verified. Hepatic metabolism must also be considered. Drug interactions must be evaluated. Duplicate therapies must be identified. The pharmacist prepares evidence-based recommendations. During rounds, the pharmacist presents medication-related findings. These recommendations are discussed with the entire care team. Pharmacotherapy decisions are therefore collaborative. This model improves patient outcomes. Neurocritical care patients often receive complex medication regimens. Sedatives, vasopressors, anticonvulsants, and osmotic agents may all be used simultaneously. Polypharmacy significantly increases the risk of medication-related complications. The pharmacist helps prevent these complications. Medication safety becomes a primary responsibility. During rounds, the pharmacist frequently recommends dose adjustments. Renal impairment is common in critically ill patients. Acute kidney injury alters drug clearance. Drug accumulation may occur rapidly. The pharmacist adjusts his dosing intervals appropriately. Therapeutic drug monitoring may also be required. Phenytoin levels must be interpreted carefully. Protein binding may be altered in critically ill patients. The pharmacist interprets free drug concentrations when necessary. Vancomycin therapy also requires careful monitoring. Target exposure is defined by pharmacokinetic parameters. The pharmacist calculates appropriate dosing strategies. Sedation management is another major topic during rounds. Many neurocritical care patients require mechanical ventilation. Sedation must balance comfort and neurologic assessment. Excess sedation may obscure neurological changes. Insufficient sedation may cause agitation or ventilator dysynchrony. The pharmacist recommends optimal sedation strategies. Propofol, dexmedetomidine, and midazolam may be used. Each agent has distinct pharmacologic properties. Propofol provides rapid onset and short duration. Dexmedetomidine preserves some neurological responsiveness. Midazolam may accumulate during prolonged infusions. The pharmacist guides drug selection carefully. Hemodynamic effects must also be considered. Some sedatives may cause hypertension. Blood pressure instability may worsen cerebral perfusion. The pharmacist integrates hemodynamic and neurologic goals. Pain management is also discussed during rounds. Untreated pain can increase sympathetic activation. This may elevate intracranial pressure. The pharmacist recommends appropriate analgesics. Fentanyl is commonly used in neurocritical care. Short-acting opioids allow frequent neurologic assessment. Dose titration must be careful and precise. Seizure prevention and management are also reviewed daily. Patients with intracranial hemorrhage or traumatic brain injury may require anticonvulsants. The pharmacist reviews drug levels and seizure activity. Dose optimization improves seizure control. Adverse effects must be minimized. Osmotherapy is another critical topic during rounds. Mannitol and hypertonic saline are frequently used. These therapies reduce intracranial pressure. However, electrolyte disturbances may occur. Hyponatremia may develop during hypertonic saline therapy. The pharmacist monitors serum sodium levels closely. Osmolality must also be assessed. Excessive osmolar loads may cause renal injury. The pharmacist adjusts therapy accordingly. Anticoagulation and antiplatelet therapy must also be discussed. Stroke patients frequently require complex antithrombotic decisions. Bleeding risk must be balanced with thrombosis prevention. The pharmacist evaluates all relevant medications. Drug-drug interactions must be minimized. Gastrointestinal prophylaxis is another routine consideration. Stress-related mucosal bleeding may occur in ICU patients. The pharmacist determines whether acid suppression is necessary. Proton pump inhibitors may be used in high-risk patients. Unnecessary therapy should be avoided. The pharmacist promotes rational prescribing. Antimicrobial therapy may also be discussed. Neurocritical care patients may develop infections. Ventilator-associated pneumonia is common. Central line infections may also occur. The pharmacist helps select appropriate antibiotics. Antimicrobial stewardship principles are applied. Broad-spectrum antibiotics should be narrowed when possible. Culture results guide therapy refinement. The pharmacist reviews microbiology reports daily. Dose optimization ensures adequate drug exposure. Neurocritical care patients often have altered pharmacokinetics. Communication with nursing staff is essential. Infusion protocols must be understood by bedside nurses. The pharmacist provides real-time education when necessary. Residents and fellows also benefit from pharmacist teaching. Academic medical centers emphasize interdisciplinary learning. Pharmacists frequently explain pharmacologic principles during rounds. Evidence from clinical trials may be discussed. Guideline recommendations are often reviewed. This improves team knowledge and decision-making. Quality improvement initiatives are also integrated into rounds. Medication errors may be reviewed. Protocol adherence may be evaluated. Pharmacists contribute to system improvements. Their expertise strengthens medication safety culture. In large academic medical centers, research may also be discussed. Clinical trials may influence therapeutic decisions. Pharmacists help interpret emerging pharmacotherapy data. Participation in rounds therefore extends beyond medication dispensing. It represents active clinical leadership. The neurocritical care pharmacist becomes an essential therapeutic strategist. Their expertise ensures pharmacologic decisions align with neurological goals. Precision pharmacotherapy supports neurological recovery. Through daily multidisciplinary rounds, the pharmacist protects patients from medication-related harm while optimizing therapeutic outcomes. In neurocritical care, collaborative decision-making saves lives and preserves brain function. Role 7 entails comprehensive medication review and optimization in neurocritical care. Comprehensive medication review is a fundamental responsibility of the neurocritical care pharmacist. Neurocritical patients often receive complex and rapidly evolving medication regimens. Polypharmacy is extremely common in the neurocritical care unit. Many patients receive more than 10 medications simultaneously. Each drug carries potential risks. Drug interactions may occur. Adverse effects may develop. Dose accumulation may occur during organ dysfunction. The pharmacist systematically reviews every medication. This process begins immediately upon ICU admission. The pharmacist examines the patient's complete medication history. Outpatient medications must be identified accurately. Some chronic medications must be continued. Others must be temporarily discontinued. Incorrect continuation may harm the patient. Abrupt discontinuation may also cause complications. The pharmacist carefully evaluates these decisions. Medication reconciliation is therefore essential. The pharmacist verifies drug names, doses, and schedules. Errors are common during emergency admissions. Stroke and brain injury patients often arrive without complete medication records. Family members may provide partial histories. Electronic records may be incomplete. The pharmacist cross-checks multiple sources. Community pharmacy records may be consulted. Previous hospital records may provide additional information. Accuracy is essential. Once the medication history is verified, the pharmacist evaluates each drug for appropriateness. Every medication must have a clear indication. Unnecessary drugs must be discontinued. Medication burden should be minimized whenever possible. Reducing polypharmacy improves patient safety. Drug dosing is evaluated next. Critically ill patients often experience altered pharmacokinetics. Drug absorption may change. Drug distribution may change. Protein binding may be altered. Hepatic metabolism may be impaired. Renal elimination may be reduced. The pharmacist adjusts drug dosing accordingly. Renal function is a particularly important consideration. Acute kidney injury is common in critical illness. Drugs eliminated by the kidneys may accumulate. Examples include vancomycin, levetiracetam, and gabapentin. Accumulation increases toxicity risk. The pharmacist calculates creatinine clearance. Dose adjustments are implemented promptly. Hepatic impairment may also influence drug metabolism. Sedatives and anticonvulsants are often metabolized in the liver. The pharmacist monitors liver function tests. Drug selection may be modified accordingly. Drug-drug interactions are carefully evaluated. Critically ill patients often receive medications with complex interaction profiles. Cytochrome P450 enzyme interactions may alter drug concentrations. Enzyme induction may reduce drug effectiveness. Enzyme inhibition may increase toxicity. The pharmacist identifies these interactions early. Adjustments are recommended to the care team. Adverse drug reactions must also be considered. Many medications can affect neurological status. Sedatives may cause excessive sedation. Anticonvulsants may cause cognitive impairment. Opioids may cause respiratory depression. The pharmacist monitors for these complications. Early recognition prevents serious harm. Therapeutic duplication must also be avoided. Duplicate sedatives may cause profound central nervous system depression. Duplicate anticoagulants increase bleeding risk. Duplicate antihypertensives may cause dangerous hypertension. The pharmacist eliminates unnecessary duplication. Medication timing is another important consideration. Some drugs require strict administration schedules. Antibiotics may require precise dosing intervals. Missed doses may reduce treatment effectiveness. The pharmacist ensures proper scheduling. Route of administration must also be reviewed. Some patients cannot swallow medications. Enteral feeding tubes may be required. Certain drugs cannot be crushed. Modified release formulations must not be altered. The pharmacist ensures safe administration methods. Drug compatibility within intravenous lines must also be considered. Many ICU patients receive multiple IV infusions. Incompatible drugs may precipitate in IV tubing. This may cause catheter occlusion. It may also deliver inaccurate doses. The pharmacist ensures infusion compatibility. Pharmacokinetic monitoring is frequently required. Certain drugs require therapeutic drug monitoring. Phenytoin is a classic example. Total phenytoin levels may be misleading. Low albumin alters protein binding. The pharmacist calculates corrected phenytoin levels. Free drug concentrations may be measured. Vancomycin therapy also requires careful monitoring. Target exposure must be achieved. Subtherapeutic exposure risks treatment failure. Excessive exposure increases nephrotoxicity. The pharmacist adjusts dosing using pharmacokinetic models. Antimicrobial therapy must also be reviewed. Empiric antibiotics are frequently initiated in critically ill patients. However, broad-spectrum therapy should not continue indefinitely. Microbiologic culture results must guide therapy. The pharmacist recommends antimicrobial de-escalation. This supports antimicrobial stewardship. Reducing unnecessary antibiotic exposure prevents resistance. Cost considerations may also arise. Certain neurocritical medications are extremely expensive. Examples include reversal agents and specialty anticonvulsants. The pharmacist evaluates cost-effective alternatives. However, cost should never compromise patient safety. Evidence-based decision-making remains the priority. Nutrition and drug interactions must also be considered. Enteral feeding formulas may interact with medications. Phenytoin absorption may be reduced by tube feeding. The pharmacist must adjust administration timing. Medication administration may be temporarily held around feedings. Electrolyte disturbances must also be monitored. Certain drugs influence electrolyte balance. Diuretics may cause hypokalemia. Hypertonic saline may cause hyponatremia. The pharmacist monitors laboratory trends closely. Preventive pharmacotherapy is also reviewed. Stress ulcer prophylaxis may be necessary. Venous thromboembolism prophylaxis must be considered. The pharmacist ensures appropriate prophylactic therapies are prescribed. Unnecessary preventive medications should be discontinued. Medication review is not a one-time event. It occurs daily throughout ICU care. Patient conditions change rapidly. Drug regimens must adapt accordingly. The pharmacist reassesses therapy during every clinical round. Communication with the healthcare team is essential. Pharmacist recommendations are discussed with physicians and nurses. Collaborative decision-making improves outcomes. Education is also provided when necessary. Residents and fellows often learn pharmacotherapy principles during these discussions. The pharmacist contributes to interdisciplinary learning. Documentation is another key responsibility. Medication recommendations must be clearly recorded. This ensures continuity of care. Medication plans must be updated accordingly. The pharmacist ensures safe handover during these transitions. Quality improvement initiatives also depend on medication review. Pharmacists track medication errors. Adverse drug events are analyzed. System improvements are implemented when needed. Academic centers often use these data for research. Pharmacists frequently participate in medication safety studies. Their findings improve neurocritical care practice. Ultimately, comprehensive medication review protects patients from preventable harm. Medication errors can cause devastating neurological consequences. The pharmacist acts as the final safeguard. Through meticulous review and optimization, the neurocritical care pharmacist ensures that every medication contributes to recovery rather than harm. Precision in pharmacotherapy protects the vulnerable brain. Role 8 entails pharmacologic management of intracranial pressure. Intracranial pressure management is central to neurocritical care. Elevated intracranial pressure threatens cerebral perfusion. Uncontrolled ICP can rapidly lead to brain herniation. The neurocritical care pharmacist plays a vital role in pharmacologic ICP control. Brain injury often leads to cerebral edema. Cytotoxic and vasogenic edema both contribute to rising intracranial pressure. Stroke, traumatic brain injury, and intracranial hemorrhage commonly cause this complication. The pharmacist ensures rapid initiation of evidence-based therapies. ICP monitoring is frequently used in severe cases. Intraventricular catheters or intraparenchymal probes measure intracranial pressure continuously. Normal ICP typically ranges from 5 to 15 millimeters of mercury. Sustained ICP above 20 to 22 millimeters of mercury requires intervention. The pharmacist collaborates closely with neurointensivists during these events. Osmotherapy is the cornerstone of pharmacologic ICP management. Osmotic agents reduce cerebral edema by creating osmotic gradients. These gradients draw water from brain tissue into the vascular space. Two major agents are commonly used. Mannitol and hypertonic saline are the primary therapies. Each drug has unique pharmacologic properties. The pharmacist helps determine which therapy is most appropriate. Mannitol has historically been the standard osmotic agent. It is an osmotic diuretic. It increases plasma osmolality. This pulls water out of edematous brain tissue. Mannitol is typically administered as an intravenous infusion. Common doses range from 0.25 to 1 gram per kilogram infused over 30 to 60 minutes. A rapid administration is necessary. The pharmacist ensures correct dosing calculations. Precise dosing is critical. Excessive dosing may cause complications. Mannitol produces significant diuresis. Volume depletion may occur. Hypertension may follow excessive diuresis. Reduced blood pressure may reduce cerebral perfusion pressure. The pharmacist carefully monitors fluid balance. Serum osmolality must also be monitored. Osmolality above 320 milliosmoles per kilogram increases renal injury risk. The pharmacist tracks laboratory trends closely. Renal function must also be evaluated regularly. Mannitol accumulation may occur during renal impairment. This may worsen cerebral edema instead of improving it. The pharmacist identifies these situations early. Hypertonic saline has become increasingly popular. Many neurocritical care units now prefer hypertonic saline. Hypertonic saline increases serum sodium concentration. This creates a strong osmotic gradient. Water shifts from brain tissue into the intravascular space. ICP subsequently decreases. Hypertonic saline also improves hemodynamics. It expands intravascular volume. This supports cerebral perfusion pressure. The pharmacist prepares hypertonic saline protocols. Several concentrations are used clinically. Common solutions include 3%, 7.5%, and 23.4% sodium chloride. Lower concentrations may be administered as continuous infusions. Higher concentrations are typically given as boluses. The pharmacist ensures safe administration. Central venous access is often required. Highly concentrated solutions may damage peripheral veins. Serum sodium monitoring is essential. Rapid sodium shifts can be dangerous. The pharmacist monitors sodium levels frequently. Target sodium concentrations may range from 145 to 155 milliequivalents per liter. Excessive hyponatremia must be avoided. Sodium levels above 160 milliequivalents per liter increase complications. The pharmacist helps titrate therapy carefully. Serum osmolality must also be monitored. Combined osmolar loads from multiple therapies must be considered. Hyperosmolar therapy may interact with other ICU medications. Loop diuretics may intensify electrolyte loss. The pharmacist monitors potassium and magnesium levels. The pharmacist corrects abnormalities promptly. Repeated ICP spikes may require multiple interventions. Sedation may help reduce metabolic demand. The pharmacist evaluates sedative strategies. Propofol is frequently used in severe brain injury. It reduces cerebral metabolic activity. This reduces cerebral blood flow and ICP. The pharmacist ensures appropriate propofol dosing. High doses may cause hypertension. Hypertension threatens cerebral perfusion. Careful titration is essential. Barbiturate therapy may be required in refractory cases. Pentobarbital coma reduces cerebral metabolic activity profoundly. This strategy is reserved for severe ICP crises. The pharmacist calculates loading and maintenance doses. Hemodynamic monitoring is essential during barbiturate therapy. Hypotension frequently occurs. Vasopressor support may be necessary. The pharmacist coordinates these therapies with the ICU team. Temperature management may also influence ICP. Fever increases cerebral metabolic demand. Antipyretic therapy may help reduce ICP indirectly. The pharmacist ensures timely administration of antipyretics. Seizure prevention also plays a role. Seizures increase cerebral metabolic demand dramatically. Anticonvulsant therapy may therefore support ICP control. The pharmacist ensures therapeutic drug levels. Continuous EEG monitoring may guide therapy. ICP pharmacotherapy must always be integrated with non-pharmacologic strategies. Head elevation improves venous drainage. Ventilation strategies may influence cerebral blood flow. Hyperventilation may temporarily reduce ICP. However, excessive hyperventilation may reduce cerebral perfusion. The pharmacist ensures pharmacologic therapy aligns with ventilatory management. Monitoring is continuous throughout treatment. ICP values must be interpreted alongside clinical findings. Pupil changes may signal impending herniation. Neurological deterioration demands immediate response. The pharmacist ensures emergency medications are available. Rapid response protocols are essential. Medication preparation time must be minimal. Neurocritical emergencies evolve rapidly. Quality improvement initiatives often evaluate ICP management. Pharmacists contribute to protocol development. Standardized osmotherapy protocols improve response times. Education is another important responsibility. Residents and fellows must understand ICP pharmacotherapy. Nurses must understand infusion titration protocols. The pharmacist provides ongoing training. Academic medical centers frequently conduct research in this field. Pharmacists contribute to studies comparing osmotic agents. Evidence continues to evolve. Future therapies may further refine ICP management. Throughout these developments, the pharmacist remains essential. Precision dosing prevents complications. Close monitoring protects vulnerable brain tissue. The Neurocritical Care Pharmacist ensures pharmacologic ICP management is safe, rapid, and evidence-based. Protecting the brain from pressure-related injury preserves neurological function and improves survival in critically ill patients. Role 9 entails pharmacologic seizure prevention and management in neurocritical care. Seizures are a common and dangerous complication in neurocritical illness. They frequently occur after stroke, intracranial hemorrhage, traumatic brain injury, and neurosurgical procedures. Even a single seizure can worsen neurological injury. Seizures increase cerebral metabolic demand. This leads to increased cerebral blood flow. Intracranial pressure may rise rapidly. Secondary brain injury may follow. The Neurocritical Care Pharmacist plays a central role in seizure prevention and management. Early identification of high-risk patients is essential. Patients with intracerebral hemorrhage carry a significant seizure risk. Cortical involvement increases this risk. Subarachnoid hemorrhage also predisposes patients to seizures. Traumatic brain injury is another major cause. Penetrating injuries have particularly high seizure incidence. The pharmacist collaborates with neurologists to identify patients requiring prophylaxis. Anticonvulsant prophylaxis may be indicated in selected cases. Traumatic brain injury patients often receive seizure prophylaxis for 7 days. This reduces early post-traumatic seizures. However, routine long-term prophylaxis is generally not recommended. The pharmacist ensures therapy duration is appropriate. Overuse of anticonvulsants should be avoided. Drug selection is a key responsibility. Several anticonvulsants are used in neurocritical care. Levetiracetam is now widely preferred. It has a favorable safety profile. Drug interactions are minimal. Therapeutic monitoring is rarely required. The pharmacist recommends appropriate dosing. Typical loading doses range from 1,000 to 3,000 milligrams intravenously. Maintenance doses commonly range from 500 to 1,500 milligrams twice daily. Renal function must be considered. Levetiracetam is primarily renally eliminated. Dose adjustments may be required during renal impairment. The pharmacist calculates creatinine clearance carefully. Phenytoin is another commonly used anticonvulsant. It has been used for decades in neurocritical care. However, phenytoin pharmacokinetics are complex. Protein binding significantly influences drug levels. Critically ill patients often have low albumin levels. This alters free phenytoin concentrations. Total phenytoin levels may therefore be misleading. The pharmacist calculates corrected phenytoin concentrations. Free phenytoin levels may also be measured directly. Loading doses must be precise. Typical phenytoin loading doses are 15 to 20 milligrams per kilogram. Infusion rates must be carefully controlled. Rapid infusion may cause hypertension. Cardiac arrhythmias may occur. Continuous cardiac monitoring is required during infusion. Fosphenytoin is often preferred for intravenous loading. It is a prodrug of phenytoin. It can be infused more rapidly. It causes fewer infusion-related complications. The pharmacist ensures appropriate infusion protocols. Valproic acid may also be used in certain cases. It is particularly useful in refractory seizures. Typical loading doses range from 20 to 40 milligrams per kilogram. However, valproic acid requires careful monitoring. Hepatic toxicity is possible. Thrombocytopenia may also occur. The pharmacist monitors liver function tests and platelet counts. Lacosamide is another emerging anticonvulsant option. It is often used as adjunct therapy. Typical loading doses range from 200 to 400 milligrams. Maintenance therapy usually involves twice-daily dosing. The pharmacist ensures dosing adjustments in renal impairment. Drug interactions must always be evaluated. Many anticonvulsants interact with other medications. Phenytoin strongly induces hepatic enzymes. This may reduce levels of other drugs. Warfarin metabolism may be affected. Certain antibiotics may alter anticonvulsant levels. The pharmacist continuously monitors for these interactions. Continuous EEG monitoring is frequently used in neurocritical care. Non-convulsive seizures may occur without visible motor activity. These seizures can still cause brain injury. EEG monitoring helps detect these silent events. The pharmacist collaborates with neurologists in interpreting results. Anticonvulsant therapy may be adjusted based on EEG findings. Status epilepticus is a neurologic emergency. Immediate treatment is required. First-line therapy typically involves benzodiazepines. Lorazepam is commonly used. Typical doses are 0.1 milligrams per kilogram intravenously. Rapid administration is required. If seizures persist, second-line therapy is initiated. Levetiracetam, fosphenytoin, or valproic acid may be used. The pharmacist prepares these medications rapidly. Accurate dosing is essential. Refractory status epilepticus may require continuous sedation. Propofol infusions are commonly used. Midazolam infusions are another option. The pharmacist manages dosing and monitoring. Hemodynamic instability may occur during these therapies. Blood pressure monitoring is essential. Vasopressors may be required. The pharmacist integrates these therapies carefully. Electrolyte disturbances must also be corrected. Hyponatremia may precipitate seizures. Hypocalcemia may also contribute. Magnesium deficiency may lower seizure threshold. The pharmacist ensures electrolyte abnormalities are corrected promptly. Medication adherence becomes important during recovery. Patients discharged on anticonvulsants require careful counseling. Missed doses may trigger seizures. The pharmacist provides detailed education. Driving restrictions may also apply. Patients must understand safety precautions. Therapy duration must be reviewed periodically. Some patients require only short-term prophylaxis. Others require long-term anticonvulsant therapy. Neurologists determine long-term management. The pharmacist supports these decisions with pharmacologic expertise. Adverse effects must be monitored carefully. Sedation is common with many anticonvulsants. Cognitive impairment may occur. Mood changes may also develop. The pharmacist helps identify safer alternatives when necessary. Transitions of care require meticulous planning. Medication lists must be updated at discharge. Outpatient follow-up must be arranged. Anticonvulsant monitoring may continue after hospitalization. Pharmacist often coordinates these transitions. Quality improvement programs track seizure management outcomes. Pharmacists frequently analyze anticonvulsant use. Protocol adherence may be evaluated. Continuous improvement strengthens neurocritical care systems. Education of trainees is another responsibility. Residents and fellows must understand anticonvulsant pharmacology. The pharmacist provides teaching during rounds and conferences. Research also continues in this field. New anticonvulsants are under development. Precision medicine may guide future therapy. Genetic factors may influence anticonvulsant response. A pharmacist remains central to these advances. Ultimately, seizure prevention protects vulnerable neural tissue. Prompt seizure treatment prevents secondary brain injury. Through expert pharmacologic management, the neurocritical care pharmacist safeguards neurological recovery and improves outcomes for critically ill patients. Role 10 entails optimization of osmotherapy for intracranial pressure management. Elevated intracranial pressure is one of the most dangerous complications in neurocritical care. It commonly occurs in patients with traumatic brain injury. It is also seen after intracerebral hemorrhage. Large ischemic strokes can also produce severe cerebral edema. Brain tumors and central nervous system infections may also cause intracranial hypertension. If intracranial pressure rises significantly, cerebral perfusion becomes compromised. Reduced cerebral perfusion leads to brain ischemia. Herniation syndromes may occur if pressure is not rapidly controlled. Early recognition and treatment are therefore essential. Osmotherapy is a cornerstone of pharmacologic intracranial pressure management. The neurocritical care pharmacist plays a central role in optimizing osmotic therapy. Two primary agents are commonly used. These include mannitol and hypertonic saline. Both medications reduce intracranial pressure through osmotic mechanisms. They draw water from brain tissue into the intravascular compartment. This reduces cerebral edema and improves intracranial compliance. Appropriate patient selection is the first step. Not all patients with neurologic injury require osmotherapy. The pharmacist evaluates clinical indications carefully. Signs of elevated intracranial pressure include declining neurological status. Pupillary changes may occur. Imaging may demonstrate significant cerebral edema. Intracranial pressure monitoring devices may confirm elevated pressure. When osmotherapy is indicated, drug selection becomes critical. Mannitol has been used for decades in neurocritical care. It is an osmotic diuretic. It increases plasma osmolality. Water is drawn from the brain into the bloodstream. Mannitol also improves cerebral microcirculation. Typical dosing ranges from 0.25 to 1 gram per kilogram intravenously. The pharmacist calculates weight-based dosing precisely. Doses are usually administered as intermittent infusions. Rapid administration may be required in acute neurologic deterioration. However, mannitol therapy carries important risks. Excessive dosing may lead to dehydration. Hypotension may occur due to diuresis. Electrolyte disturbances are common. Hypokalemia and hyponatremia may develop. Renal function must also be monitored carefully. Mannitol is filtered by the kidneys. Accumulation may occur in renal impairment. Repeated doses can lead to osmotic nephrosis. The pharmacist monitors serum osmolality closely. Most protocols recommend maintaining osmolality below 320 milliosmoles per kilogram. Exceeding this threshold increases the risk of renal injury. The osmolar gap may also be calculated. This helps detect mannitol accumulation. Hypertonic saline is another powerful osmotic therapy. It has become increasingly favored in neurocritical care. Unlike mannitol, hypertonic saline expands intravascular volume. This may improve cerebral perfusion pressure. Several concentrations are available. Common formulations include 3% saline. More concentrated solutions such as 7.5% or 23.4% saline may also be used. Drug administration protocols vary depending on the concentration. 3% saline may be given as intermittent boluses or continuous infusions. Typical bolus doses range from 150 to 250 milliliters. Continuous infusions require careful titration. The pharmacist ensures infusion rates align with institutional protocols. Serum sodium must be monitored frequently. Sodium levels typically target a mild hyponatremic range. Targets often range from 145 to 155 milliequivalents per liter. Rapid sodium correction must be avoided. Overly rapid changes increase the risk of osmotic demyelination syndrome. The pharmacist carefully tracks sodium trends. Laboratory monitoring is essential during osmotherapy. Serum sodium is measured frequently. Serum osmolality must also be monitored. Electrolytes including potassium, chloride, and bicarbonate are evaluated. Renal function is assessed through serum creatinine and urine output. The pharmacist integrates these laboratory values into dosing decisions. Hemodynamic monitoring is also important. Hypertonic saline can increase intravascular volume. Fluid overload may occur in susceptible patients. Patients with heart failure require additional caution. Central venous access is often required for concentrated saline. The pharmacist ensures proper administration safety. Compatibility with other intravenous medications must be evaluated. Drug-drug interactions may also influence osmotherapy. Certain diuretics may worsen electrolyte disturbances. Loop diuretics may be used in combination with hypertonic saline in some cases. This approach may enhance osmotic effectiveness. The pharmacist evaluates these strategies carefully. Monitoring neurological response is equally important. Reduction in intracranial pressure should improve neurologic status. Pupillary reactivity may improve. Intracranial pressure monitor readings may decline. The pharmacist collaborates closely with intensivists and neurosurgeons. Therapy adjustments are made rapidly based on patient response. Rebound intracranial hypertension is another important consideration. This may occur when osmotic agents are discontinued abruptly. Gradual tapering may sometimes be required. The pharmacist helps guide safe discontinuation strategies. Patients with prolonged therapy require even closer monitoring. Cumulative osmotic exposure may increase complication risks. Fluid balance becomes increasingly important. Urine output trends must be reviewed regularly. Special populations require additional consideration. Patients with renal failure may tolerate mannitol poorly. Hypertonic saline may be preferred in these situations. Patients with severe hypovolemia may also benefit from saline therapy. The pharmacist helps individualize therapy. Emergency use of concentrated hypertonic saline may occur. 23.4% saline is sometimes used for acute herniation. This is typically administered as a small intravenous bolus. Administration requires extreme caution. The pharmacist ensures strict adherence to protocol. Rapid neurologic improvement may occur if herniation is reversed. Education of ICU staff is another key pharmacist role. Nurses must understand proper osmotherapy administration. Monitoring requirements must be clearly communicated. Protocols for sodium monitoring are reinforced. Pharmacists frequently participate in protocol development. Institutional guidelines help standardize osmotherapy use. These guidelines reduce medication errors. They also improve treatment consistency across care teams. Quality improvement initiatives may evaluate osmotherapy outcomes. Rates of electrolyte complications may be tracked. Intracranial pressure control metrics may also be analyzed. Pharmacists frequently lead these evaluations. Research continues to refine osmotherapy strategies. Optimal sodium targets remain an area of investigation. Comparisons between mannitol and hypertonic saline are ongoing. The neurocritical care pharmacist contributes to these advancements. Transitions of care must also be managed carefully. Patients leaving the ICU may still require sodium monitoring. Medication adjustments may be necessary. Clear documentation ensures safe continuity of care. Ultimately, effective osmotherapy protects vulnerable brain tissue. Careful pharmacologic management prevents secondary brain injury. Through precise dosing, vigilant monitoring, and multidisciplinary collaboration, the neurocritical care pharmacist plays a vital role in controlling intracranial pressure and improving neurological outcomes in critically ill patients. Role 11 entails status epilepticus management in neurocritical care. Status epilepticus is one of the most time-sensitive neurologic emergencies in critical care. It occurs when seizures last longer than 5 minutes. It may also occur when multiple seizures happen without recovery of consciousness between episodes. Prolonged seizure activity can cause severe neuronal injury. Metabolic demand in the brain rises dramatically during seizures. Cerebral oxygen consumption increases. Glucose utilization increases. Cerebral blood flow may initially rise, but eventually becomes inadequate. This imbalance can lead to neuronal damage. Systemic complications also occur. Hypoxia may develop, lactic acidosis may worsen, cardiac arrhythmias can occur. If status epilepticus is not treated rapidly, permanent neurological injury may result. Mortality rates increase significantly with delayed treatment. Rapid pharmacologic intervention is therefore critical. The Neurocritical Care Pharmacist plays a key role in managing this emergency. One of the pharmacist's primary responsibilities is ensuring rapid medication availability. Time to treatment strongly influences outcomes. Antiepileptic medications must be prepared immediately. Accurate dosing is essential during emergency administration. Treatment follows a stepwise pharmacologic approach. First-line therapy involves benzodiazepines. These drugs enhance inhibitory neurotransmission in the brain. They act by potentiating gamma-aminobutyric acid receptors. This helps suppress seizure activity rapidly. Lorazepam is commonly used in hospital settings. Typical dosing is 0.1 milligrams per kilogram intravenously. The maximum single dose is usually 4 milligrams. The medication should be administered slowly over 2 minutes. The pharmacist ensures appropriate dosing and preparation. Diazepam may also be used when lorazepam is unavailable. It has a rapid onset of action. However, its duration is shorter. Midazolam is another option. It is commonly used in pre-hospital or intramuscular administration. Intramuscular midazolam can be life-saving when intravenous access is not available. The pharmacist ensures that emergency medication kits contain appropriate benzodiazepines. If seizures continue after benzodiazepine administration, second-line therapy is required. This stage is referred to as established status epilepticus. Several anti-epileptic medications may be used. Levetiracetam is increasingly preferred. It has minimal drug interactions. It is generally well tolerated. Typical loading doses range from 1,000 to 4,500 milligrams infused intravenously over 15 minutes. The pharmacist calculates appropriate weight-based dosing at 60 milligrams per kilogram. Fosphenytoin is another commonly used agent. It is a prodrug of phenytoin. It can be administered more rapidly than phenytoin. Typical loading doses are 20 milligrams phenytoin equivalents per kilogram. Infusion rates must still be monitored carefully. Cardiac monitoring is required during administration. The pharmacist ensures adherence to safe infusion limits. Valproic acid is another second-line option. Typical loading doses range from 20 to 40 milligrams per kilogram. It is particularly useful in patients with certain seizure syndromes. However, hepatic function must be evaluated before administration. The pharmacist reviews liver function tests carefully. Platelet counts must also be monitored. Lacosamide may also be used as adjunctive therapy. It works through sodium channel modulation. Typical loading doses range from 200 to 400 milligrams intravenously. It is dosed at 10 to 12 milligrams per kilogram at an infusion rate of 0.4 milligram per kilogram per minute. This is safe and will produce levels of 15 micrograms per milliliter and higher. The pharmacist helps determine appropriate drug selection based on patient factors. Certain medications may be preferred in specific populations. For example, valproic acid may be avoided in severe hepatic disease. Phenytoin may be avoided in patients with cardiac conduction abnormalities. Renal function also influences medication choice. The pharmacist evaluates these variables rapidly during treatment decisions. Drug compatibility and administration logistics are also important. Many antiepileptic drugs require specific infusion solutions. Incompatible medications must not be mixed in the same intravenous line. The pharmacist provides guidance to nursing staff during preparation and administration. Therapeutic monitoring becomes essential after loading doses. Phenytoin levels must be monitored carefully. Critically ill patients often have altered protein binding. Low albumin levels can increase free drug concentrations. Total phenytoin levels may therefore be misleading. The pharmacist calculates corrected phenytoin concentrations. Free phenytoin levels may also be measured directly. If seizures persist despite second-line therapy, refractory status epilepticus is diagnosed. This is a life-threatening condition. Continuous anesthetic infusions may be required. Propofol is commonly used in these situations. Midazolam infusions are another option. Pentobarbital may be used in severe refractory cases. These medications suppress cortical electrical activity. Continuous electroencephalographic monitoring becomes essential. The pharmacist collaborates closely with neurologists and intensivists during this stage. Medication titration must balance seizure suppression with hemodynamic stability. Many sedative agents cause hypotension. Vasopressor support may be required. The pharmacist evaluates potential drug interactions with vasopressors and sedatives. Metabolic disturbances must also be corrected. Electrolyte abnormalities can worsen seizures. Hyponatremia is a common precipitating factor. Hypocalcemia may also contribute. Magnesium deficiency may lower seizure threshold. Hypoglycemia must also be corrected rapidly. The pharmacist reviews laboratory values continuously. Seizure triggers should be investigated. Central nervous system infections may be responsible. Acute stroke may precipitate seizures. Medication toxicity may also play a role. The pharmacist evaluates current medication lists carefully. Certain antibiotics can lower seizure threshold. Carbapenems are known to increase seizure risk. High doses of certain antidepressants may also contribute. The pharmacist helps identify and discontinue offending agents. Medication safety during status epilepticus management is critical. Dosing errors may occur in emergency settings. The pharmacist helps prevent these errors. Standardized treatment protocols improve care consistency. Many hospitals implement status epilepticus algorithms. The pharmacist often participates in developing these protocols. Simulation training may also involve pharmacists. Emergency response teams benefit from rehearsing rapid medication preparation. These exercises improve response time during real events. Transitions of care must also be considered. Patients recovering from status epilepticus may require long-term anticonvulsant therapy. The pharmacist helps determine appropriate maintenance regimens. Therapeutic drug monitoring may continue after ICU discharge. Outpatient follow-up must be arranged. Medication adherence becomes extremely important. Missed doses may trigger seizure recurrence. The pharmacist provides detailed counseling to patients and families. Education includes dosing schedules and potential adverse effects. Driving restrictions may also apply after seizure events. Patients must understand these safety considerations. Research continues to improve status epilepticus treatment strategies. New anti-epileptic medications are under investigation. Earlier combination therapy may improve outcomes. Precision medicine approaches may also guide drug selection in the future. The Neurocritical Care Pharmacist contributes to these advancements through research and quality improvement initiatives. Ultimately, rapid and accurate pharmacologic intervention is essential in status epilepticus. Each minute of uncontrolled seizure activity increases the risk of brain injury. Through expert medication management, rapid preparation of emergency therapies, and continuous monitoring, the Neurocritical Care Pharmacist plays a critical role in stopping seizures and protecting neurological function in critically ill patients. Role 12 entails seizure prophylaxis in brain injury and intracranial hemorrhage. Seizures are a frequent complication in patients with acute neurological injury. They commonly occur after traumatic brain injury. They may also develop following intracerebral hemorrhage. Subarachnoid hemorrhage can also increase seizure risk. Neurosurgical procedures may further predispose patients to seizures. Even a single seizure can worsen neurological injury. Seizure activity increases cerebral metabolic demand. Oxygen consumption rises significantly. Glucose utilization increases as well. Cerebral blood flow may increase initially. However, sustained seizure activity can worsen cerebral edema. Intracranial pressure may rise rapidly. Secondary brain injury may occur. Preventing seizures is therefore an important goal in neurocritical care. The Neurocritical Care Pharmacist plays a central role in seizure prophylaxis. Careful identification of high-risk patients is the first step. Not every patient with neurological injury requires prophylactic anticonvulsants. Evidence-based selection is essential. Unnecessary treatment exposes patients to avoidable drug toxicity. Traumatic brain injury is one of the most common indications for seizure prophylaxis. Early post-traumatic seizures typically occur within 7 days of injury. These seizures can worsen intracranial hypertension. They may also exacerbate neuronal damage. Clinical guidelines recommend short-term anticonvulsant prophylaxis in moderate to severe traumatic brain injury. The recommended duration is typically 7 days. Prophylaxis beyond this period is generally not recommended unless seizures occur. The pharmacist ensures therapy duration aligns with evidence-based recommendations. Intracerebral hemorrhage also carries a risk of seizures. Patients with cortical involvement are particularly vulnerable. Large hematomas increase seizure risk. The pharmacist works with neurologists to evaluate individual patient risk. Routine prophylaxis is not always recommended. Selective use is often preferred. Subarachnoid hemorrhage is another condition associated with seizures. Seizures may occur due to irritation of cortical tissue by blood products. They may also occur during aneurysm rupture. Short-term anticonvulsant prophylaxis may be considered in certain patients. However, prolonged therapy may worsen cognitive outcomes. The pharmacist helps balance potential benefits and risks. Drug selection is a critical responsibility. Several anticonvulsant medications may be used for seizure prophylaxis. Levetiracetam has become the most commonly used agent. It has a favorable safety profile. Drug interactions are minimal. Sedation is generally mild compared with older anticonvulsants. Levetiracetam also has predictable pharmacokinetics. Therapeutic drug monitoring is usually unnecessary. Typical dosing ranges from 500 to 1,500 milligrams twice daily. Intravenous administration is often used in critically ill patients. The pharmacist ensures appropriate dosing based on patient weight and renal function. Renal clearance is the primary elimination pathway. Dose adjustments are required in renal impairment. The pharmacist carefully calculates creatinine clearance. Phenytoin has historically been used for seizure prophylaxis. It remains an alternative in some institutions. However, phenytoin pharmacokinetics are complex. Protein binding significantly influences drug levels. Critically ill patients frequently have low albumin levels. This increases the fraction of free phenytoin. Total serum levels may therefore be misleading. The pharmacist calculates corrected phenytoin levels. Free phenytoin concentrations may also be measured directly. Loading doses must be calculated carefully. Typical loading doses range from 15 to 20 milligrams per kilogram. Infusion rates must be controlled carefully. Rapid infusion may cause hypotension. Cardiac arrhythmias may occur. Continuous cardiac monitoring is required. Fosphenytoin may be used as an alternative formulation. It is a prodrug of phenytoin. It allows faster infusion rates. It also causes fewer infusion site reactions. The pharmacist ensures proper dosing conversions between fosphenytoin and phenytoin. Monitoring for adverse effects is another important pharmacist responsibility. Anticonvulsants may produce central nervous system side effects. Sedation is common. Cognitive slowing may occur. These effects may complicate neurological assessments. The pharmacist helps clinicians distinguish medication effects from neurologic deterioration. Hematologic effects must also be monitored. Phenytoin may cause leukopenia. Thrombocytopenia may also occur. Liver function abnormalities may develop. The pharmacist monitors laboratory parameters carefully. Drug interactions represent another important concern. Phenytoin strongly induces hepatic enzymes. This may alter metabolism of other medications. Anticoagulants may be affected. Certain antibiotics may interact with anticonvulsants. The pharmacist continuously evaluates medication regimens for potential interactions. Electrolyte abnormalities may lower seizure threshold. Hyponatremia is particularly important. Hypocalcemia may also contribute. Magnesium deficiency may increase seizure risk. The pharmacist ensures electrolyte disturbances are corrected promptly. Continuous electroencephalographic monitoring may be used in certain patients. Non-convulsive seizures can occur without obvious motor activity. These seizures can still cause neurological damage. EEG monitoring helps detect these silent seizures. The pharmacist collaborates with neurologists in interpreting EEG findings. Anticonvulsant therapy may be adjusted based on EEG results. Duration of prophylaxis must be reassessed regularly. Patients with traumatic brain injury typically discontinue prophylaxis after 7 days if no seizures occur. Continuing therapy unnecessarily exposes these patients to adverse effects. The pharmacist ensures timely discontinuation when appropriate. Transitions of care require careful coordination. Patients discharged from the ICU may still be receiving anticonvulsants. Clear documentation of therapy indication is essential. Duration of therapy must be specified. Follow-up with neurology may be required. The pharmacist ensures medication reconciliation is accurate at discharge. Patient and family education is also important. Patients should understand why anticonvulsants were prescribed. They must also understand when therapy will stop. Unnecessary continuation of prophylaxis is a common problem. Pharmacists help prevent this through clear communication. Quality improvement initiatives may evaluate anticonvulsant prophylaxis practices. Rates of inappropriate long-term therapy may be monitored. Pharmacists often lead these medication stewardship efforts. Education of healthcare professionals is also essential. Residents and nurses must understand current evidence regarding seizure prophylaxis. The pharmacist frequently teaches these concepts during ICU rounds and educational sessions. Research continues to refine seizure prevention strategies. New anticonvulsants are being studied. Biomarkers may eventually help identify patients at highest seizure risk. The Neurocritical Care Pharmacist contributes to these advancements through clinical research and protocol development. Ultimately, seizure prevention protects vulnerable brain tissue. Avoiding unnecessary anticonvulsant therapy is equally important. Through careful patient selection, appropriate drug choice, precise dosing, and vigilant monitoring, the Neurocritical Care Pharmacist plays a critical role in preventing seizures and improving neurological outcomes in patients with acute brain injury. Role 13 entails prevention of cerebral vasospasm in subarachnoid hemorrhage. Cerebral vasospasm is one of the most serious complications following aneurysmal subarachnoid hemorrhage. It typically occurs several days after the initial hemorrhage. The risk period usually begins around day 3. Peak incidence occurs between day 6 and 10. Vasospasm involves narrowing of cerebral arteries. This reduces cerebral blood flow. Delayed cerebral ischemia may develop. Neurological deterioration can occur rapidly. Stroke may result if perfusion is not restored. Preventing vasospasm is therefore a major goal in neurocritical care. The Neurocritical Care Pharmacist plays a critical role in vasospasm prevention. Early pharmacologic therapy is essential. The cornerstone of vasospasm prevention is nimodipine therapy. Nimodipine is a calcium channel blocker. It selectively targets cerebral vascular smooth muscle. By blocking calcium influx, it helps prevent arterial constriction. This reduces the risk of delayed cerebral ischemia. Clinical studies have demonstrated improved neurological outcomes with nimodipine therapy. For this reason, it is recommended for nearly all patients with aneurysmal subarachnoid hemorrhage. The pharmacist ensures nimodipine is initiated promptly. Therapy should begin as soon as the diagnosis of subarachnoid hemorrhage is confirmed. Typical dosing is 60 milligrams orally every 4 hours. Treatment is usually continued for 21 days. The pharmacist ensures dosing schedules are maintained consistently. Missed doses can reduce protective effects. Administration challenges often occur in critically ill patients. Many patients are intubated and mechanically ventilated. Oral medications may not be feasible. In these cases, nimodipine capsules may be administered through a feeding tube. The pharmacist ensures proper preparation techniques. Capsules should never be administered intravenously. Accidental intravenous administration has caused fatal outcomes in the past. Clear labeling and staff education are essential. Hypertension is the most common adverse effect of nimodipine. This occurs because calcium channel blockade can cause systemic vasodilation. Hypertension may compromise cerebral perfusion. The pharmacist carefully monitors blood pressure trends. Dose adjustments may be necessary if hypertension occurs. Some institutions reduce the dose to 30 milligrams every 2 hours. This maintains the same total daily dose while reducing peak hypertensive effects. The pharmacist helps guide these adjustments. Blood pressure management is closely linked to vasospasm prevention. Adequate cerebral perfusion pressure must be maintained. Aggressive blood pressure lowering should be avoided in these patients. The pharmacist collaborates with the ICU team to balance blood pressure control and cerebral perfusion. Intravenous vasopressors may sometimes be required. These medications help maintain adequate perfusion pressure. The pharmacist monitors for interactions between vasopressors and other ICU medications. Volume status also influences vasospasm risk. Hypovolemia may worsen cerebral ischemia. The pharmacist helps guide fluid management strategies. Balanced fluid therapy supports cerebral perfusion. Electrolyte disturbances are common in subarachnoid hemorrhage. Hyponatremia frequently develops. This may occur due to cerebral salt wasting syndrome. Syndrome of inappropriate antidiuretic hormone secretion may also occur. Severe hyponatremia can worsen neurological outcomes. The pharmacist monitors sodium levels carefully. Hypertonic saline or salt supplementation may be required. Fludrocortisone may also be used in certain cases. The pharmacist helps determine appropriate therapy. Continuous neurologic monitoring is essential during the vasospasm risk period. Patients may develop new neurological deficits. Confusion may worsen, weakness may develop. Speech disturbances may occur. The pharmacist participates in multidisciplinary discussions when neurological changes occur. Medication adjustments may be necessary. Transcranial Doppler ultrasound is commonly used to monitor vasospasm. This non-invasive test measures blood flow velocity in cerebral arteries. Increased velocity suggests arterial narrowing. The pharmacist collaborates with neurologists when interpreting these findings. Pharmacologic therapy may need adjustment if vasospasm develops. If symptomatic vasospasm occurs, additional treatments may be required. Hemodynamic augmentation may be used. Blood pressure may be increased to improve cerebral perfusion. The pharmacist ensures antihypertensive medications are adjusted appropriately. Vasopressor therapy may be initiated. Drug dosing must be carefully titrated. Endovascular interventions may also be performed. Balloon angioplasty may mechanically dilate narrowed vessels. Intra-arterial vasodilators may also be administered. Medications such as nicardipine or verapamil may be delivered directly into cerebral arteries. The pharmacist helps ensure appropriate medication preparation and dosing. Drug interactions remain an important consideration. Nimodipine is metabolized by hepatic enzymes. Certain medications may increase or decrease its concentration. Strong CYP3A4 inhibitors may raise nimodipine levels. This increases the risk of hypotension. The pharmacist reviews medication lists carefully to prevent harmful interactions. Antifungal agents and certain antibiotics may interact with nimodipine. The pharmacist provides recommendations to avoid these combinations when possible. Nutrition management also interacts with pharmacotherapy. Enteral feeding schedules may affect nimodipine absorption. The pharmacist coordinates administration times with nutrition support teams. Quality improvement programs often monitor adherence to nimodipine protocols. Delayed or missed doses are common problems. Pharmacists frequently lead medication stewardship efforts to improve compliance. Electronic medication alerts may help ensure timely dosing. Education of healthcare professionals is another important responsibility. Nurses must understand the importance of strict nimodipine scheduling. Pharmacists often provide targeted education on subarachnoid hemorrhage pharmacotherapy. Trainees in neurology and critical care also benefit from this teaching. Research continues to improve vasospasm prevention strategies. New pharmacologic agents are under investigation. Anti-inflammatory therapies may play a future role. Targeted vascular therapies are also being explored. The Neurocritical Care Pharmacist contributes to these research efforts. Data analysis and protocol development often involve pharmacist participation. Transitions of care must also be carefully managed. Patients recovering from subarachnoid hemorrhage may remain on nimodipine therapy after ICU discharge. Clear documentation ensures therapy continues for the full 21-day course. Medication reconciliation at transfer points is essential. Ultimately, prevention of cerebral vasospasm protects vulnerable brain tissue. Delayed cerebral ischemia can dramatically worsen outcomes. Through careful medication management, monitoring of adverse effects, and coordination with the Neurocritical Care Team, the pharmacist plays a crucial role in preventing vasospasm and improving recovery after subarachnoid hemorrhage. Role 14 entails management of delirium and agitation in the Neurocritical Care Unit. Delirium is a frequent complication in critically ill neurological patients. It occurs in a large proportion of Neuro ICU admissions. Patients with stroke, traumatic brain injury, and intracranial hemorrhage are particularly vulnerable. Mechanical ventilation further increases the risk. Delirium is associated with worse outcomes. Hospital stays become longer. Mortality rates may increase. Cognitive recovery may also be impaired. Delirium presents in several forms. Hyperactive delirium involves agitation and restlessness. Patients may become combative. Medical devices may be removed unintentionally. Hypoactive delirium is also common. Patients may appear withdrawn or lethargic. This form is often underdiagnosed. The neurocritical care pharmacist plays a major role in delirium prevention and treatment. Early identification is essential. Delirium screening tools are used in many ICUs. These tools help detect subtle cognitive changes. The pharmacist reviews medications that may contribute to delirium. Certain drugs can worsen cognitive dysfunction. Benzodiazepines are a common contributor. Anticholinergic medications can also provoke delirium. High-dose opioids may impair cognition. The pharmacist recommends alternative therapies when possible. Sedation strategies are carefully optimized. Non-benzodiazepine sedation is often preferred. Dexmedetomidine is frequently used in neurocritical care. It provides sedation while allowing neurological assessment. Respiratory depression is minimal. The pharmacist guides dosing and titration. Propofol may also be used for sedation. It has a rapid onset and short duration. However, hypertension may occur. Continuous monitoring is required. Agitation may require pharmacologic treatment. Antipsychotic medications are sometimes used. Loperidol has historically been common. It can control severe agitation. However, QT prolongation may occur. The pharmacist monitors electrocardiographic changes. Atypical antipsychotics may also be used. Quetiapine and olanzapine are common options. The pharmacist helps select appropriate therapy. Dosing adjustments may be needed in organ dysfunction. Electrolyte abnormalities must also be corrected. Hyponatremia may worsen delirium. Hypoxia can contribute to cognitive changes. The pharmacist monitors laboratory values closely. Non-pharmacologic interventions are also important. Sleep promotion strategies reduce delirium risk. Minimizing nighttime disturbances is helpful. Early mobilization may improve cognitive outcomes. The pharmacist supports multidisciplinary delirium prevention protocols. Family engagement can also help orient patients. Delirium prevention programs often involve pharmacists. Quality improvement initiatives frequently track delirium rates. Pharmacists analyze medication contributions to delirium risk. Protocol improvements may follow. Education is another important pharmacist responsibility. ICU staff must recognize medications that worsen delirium. Pharmacists provide training during rounds and conferences. Ultimately, careful medication management can reduce delirium severity by minimizing neurotoxic medications and optimizing sedation strategies. The neurocritical care pharmacist helps preserve cognitive function in critically ill neurological patients.